In 2018, the American Academy of Pediatrics published a policy statement entitled Ensuring Comprehensive Care and Support for Transgender and Gender-Diverse Children and Adolescents. The paper was primarily authored by Dr. Jason Rafferty, a recent graduate of Brown University's triple board residency for pediatrics, psychiatry, and child and adolescent psychiatry.
The paper you're talking about is from the American Academy of Pediatrics,
Yep.
Ensuring Comprehensive Care and Support for Transgender and Gender-Diverse Children and Adolescents. What prompted the Academy to issue this policy paper now?
So it was, we were looking every 5 years or so, the Academy looks at the papers that we have and the positions that we have. And for a long time, there was a paper on basically looking at the health needs of all LGBTQ youth. So lesbian, gay, bisexual, transgender, queer, and questioning. And that's a very large umbrella. And it includes a really sort of a wide range of health needs. And what we found in the previous positions were that it didn't get at some of these specific questions that we're talking about now that kids who are gender diverse face, and the ways that primary care, pediatricians could really become involved in the process of supporting these kids, what they could do, ways they could counsel families and educate families. And so out of that, we decided that we were going to sort of tease apart a specific paper dealing with these challenges. And that's sort of where it came from. And then also, like I said, sort of the increased social recognition. I think especially over the last, 3 to 5 years, with more people sort of coming out publicly, whether it be celebrities or people in the media, things like that, there's been a lot of discussion and a lot of misunderstanding around people who are gender diverse and some of the challenges that they face. So both of those things were sort of coming together at the same time, and the paper was the product.
While committees are listed in addition to Dr. Rafferty, the paper comes with the following statement. Dr. Rafferty conceptualized the statement, drafted the initial manuscript, reviewed and revised the manuscript, approved the final manuscript as submitted, and agrees to be accountable for all aspects of the work.
So you wrote the paper, is that correct?
Yeah.
You had a lot of people who worked with you, or you reviewed a lot of work. Talk about the process coming to this paper, which is 15 pages long, was just recently published.
Yeah. So it was, I was the one who drafted the original draft, and then it goes out through multiple rounds of review through various committees within the American Academy of Pediatrics. So there's a committee on adolescent health, there's a committee on LGBTQ health and things like that. And so, you're really talking about some of the experts in the field who work from various angles with families who have gender diverse youth, really weighing in on some of the, some of the content. And through this process, you end up with a product that's, really been vetted and really sort of stands for, becomes sort of the position of the Academy. It's not my personal position. It really is adapted because of the number of people that really weigh in on it and provide comment. And then it moves on to the, to publication and becomes part of the Academy.
The American Association of Pediatrics, the AAP, which is the professional organization of tens of thousands of pediatricians for whom gender-affirming care is the standard of care.
The paper is now frequently cited as a standard of care, but comes with the following statement. The guidance in this statement does not indicate an exclusive course of treatment or serve as a standard of medical care. The paper recommends a gender-affirmative approach to children with gender dysphoria, but does not provide specific treatment protocols.
Well, the policy itself is focused on this gender-affirming model, and not as much on some of the specifics around, what interventions, do you use hormones, things like that, that's not where we're sort of guiding a lot of primary care pediatricians.
The policy statement refers pediatricians to the treatment protocol guidelines previously published by the Endocrine Society and WPATH, the World Professional Association for Transgender Health. Medical standards of care and guidelines are based on systematic reviews of evidence, with the quality of evidence graded according to the strength of the studies relevant to the recommendations, and the current best practice for rating evidence in systematic reviews is by utilizing the Grading of Recommendations Assessment, Development, and Evaluation, or GRADE approach. This process is essential for publishing clinical recommendations, as the quality or certainty of the evidence is fundamentally important in determining the strength of any subsequent recommendation.
This cartoon shows how we look at our confidence in evidence and the magnitude of effect. It shows two meteorologists. One says to the other, I figure there's a 40% chance of showers and a 10% chance we know what we are talking about. Once again, this very much reflects effects in healthcare. It separates the magnitude of an effect, such as a 40% chance of showers, from the confidence in the evidence behind it, that the meteorologists are about 10% sure that they know what they are talking about.
Standard grade approach ranks evidence on a 4-point scale, from very low to high quality evidence, depending on the character of the studies which produced the evidence.
In the context of making recommendations, it is defined as the quality of evidence reflects the extent to which our confidence in an estimate of the effect is adequate to support a particular recommendation. In the grade approach, recognizing that the quality of evidence comes on a continuum, we do separate the categories high from moderate, from low to very low. As in other grading systems, the randomized controlled trial evidence is judged as high quality. Observational studies start as low quality. This is based on the assumption that randomization is the best method to control for unknown variables that influence effect estimates.
The WPATH standards of care depart from the standard grade approach. They did not publish their evidence grades and instead provided recommendations ranked as weak or strong without providing the quality of the evidence behind the recommendations. Returning to our metaphor, this would be akin to the meteorologist giving a prediction about the weather without telling you how strong the evidence is that led them to that conclusion. This might be acceptable for a weather report, but takes on a whole new level of importance when considering irreversible medical and surgical interventions on vulnerable children. By not publishing the quality grade of the evidence their recommendations were based upon, WPATH denied the public the transparency necessary to understand and assess the judgments made by the authors in formulating their recommendations. This lack of transparency creates a risk of unchecked biases and assumptions overriding what should be an otherwise cautious approach to strong recommendations on therapies for which there is low quality or very low quality evidence. This does not mean that we have no sense of the quality of evidence for gender-affirming therapies, however. In 2017, the Endocrine Society published their own guidelines for medical transition in children with gender dysphoria, co-sponsored by WPATH. These guidelines did follow the grade approach to evidence assessment and ranked the evidence underlying each of their recommendations. Standard grade symbols were used to indicate very low, low, moderate, or high-quality evidence. If you take an overview of the recommendations, you will see that almost all of them are based upon low or very low quality evidence, as depicted in this color-coded diagram. Recommendations shown outlined here are those for which a strong recommendation was made. It should be noted that 2 of the recommendations judged to have very low quality evidence are nonetheless given a strong recommendation. In each instance, the authors have allowed assumed values and preferences to override very low or low quality evidence to ultimately produce strong recommendations. By including the grading of the evidence, they have conceded that the evidence base of the recommendations is weak, leaving their values and preferences transparent and open to inspection and judgment. And it is in those values that critics of the guidelines see an ideological dimension to the gender affirmation model of care. Examples of such criticism include the use of non-scientific jargon such as sex assigned at birth, a notion arising from a social constructivist view of gender. This ideological theme informs other concepts such as gender identity and gender incongruence. An over-reliance on the competency of minors to make irreversible choices about complex surgical risks, future fertility, and future sexual function. This patient-led model of care with children takes precedence over the competency aspect of informed consent and tends to marginalize parental rights in medical decision-making for children. There is an alarming minimization of the significance of desistance rates and negative consequences of therapies. Risk-benefit assessments should include comparison with desistance rates in the absence of medical or surgical interventions and should be weighed in view of the ethical principle of non-maleficence. First, do no harm. Desistance should be included in informed consent discussions. Despite these issues, there are some important points reinforced by the guidelines. This includes an acknowledgement of detransition and regret, and a statement of the need for more research to understand this cohort and improve patient selection. Most significant is the acknowledgement of the reality of comorbid mental health disorders and the importance of exploring and addressing such issues prior to initiating medical or surgical transition. This brings us back to the American Academy of Pediatrics policy statement. As we have shown, it relies on the Endocrine Society and WPATH guidelines, which have a weak evidence base. But the problems don't end there. One of the most criticized aspects of the paper is its mischaracterization of watchful waiting as outdated and withholding critical support. Watchful waiting is a term for the long-standing practice of providing exploratory therapy, social and family support for children with gender dysphoria, and addressing underlying coexisting psychological conditions during childhood, allowing time which results in resolution of dysphoria in the majority of kids. The paper is able to characterize this process which produces resolution of dysphoria as problematic because it assumes that a preference for resolution of dysphoria through reconciliation with one's biologic sex and taking steps to allow that process to take place is a form of conversion therapy, and as such is both immoral and unethical in their view. This is where critics have pointed out potential problems with the citations used to support this claim. In supporting the points that conversion therapy for children with gender dysphoria is deleterious, unsuccessful, and outside the mainstream of medical practice, the paper cites 6 different references. The first citation, number 38, is a review of conversion therapy for sexual orientation in adults. Sexual orientation is separate and distinct from gender identity. Conclusions regarding sexual orientation in adults do not translate to gender identity in childhood. This citation does not support the conclusion for which it is used. Important differences between sexual orientation and gender dysphoria include homosexual or bisexual orientation in adults does not change by conversion therapy or any other intervention. Gender dysphoria in childhood desists in a large majority of cases. This fact is cited in several of the citations referenced in the AAP policy statement, but its significance in considering the ethical implications for irreversible medical and surgical treatments is absent from the paper. The second citation, number 29, is an American Academy of Child and Adolescent Psychiatry paper that is clear that in discussing conversion therapy, it is specifically addressing sexual orientation. Again, this is not relevant to childhood gender identity. In the American Academy of Pediatrics paper, Rafferty cites this reference to support the claim that affirmation is the only legitimate alternative for treating dysphoric children. However, the actual view of this reference is neutral on that question, noting a lack of evidence and pointing out that a large majority of children will resolve their dysphoria without hormones or surgery. What's more, while Rafferty's American Academy of Pediatrics paper rejected watchful waiting as outdated and outside the mainstream of clinical practice, this citation considers that approach to be the general therapeutic mode. As such, Rafferty's paper not only uses this citation to support a claim it does not make, it also withheld from readers the Academy of Childhood and Adolescent Psychiatry's actual view in support of watchful waiting. The third reference, number 39, is an editorial whose ultimate aim is to warn against making a false equivalence between conversion or reparative therapy for sexual orientation and legitimate therapy in children with gender dysphoria, especially when lawmakers enact legislation to make such therapy illegal. After pointing out that the original definition of conversion therapy has been expanded to encompass gender identity in the language of several regulations, the author warns that legislation aimed at restricting the practice of conversion therapies must be carefully worded to avoid restricting legitimate practices. As an example of such legitimate practices, the paper describes the Ontario Child, Youth and Family Gender Identity Service that was shut down due to such legislation. The clinic was widely regarded as one of the premier gender clinics internationally, and its approach included delay of affirmation in the watchful waiting paradigm with exploration of pre-existing trauma or mental illness. The author specifically states that delaying affirmation should not be construed as conversion therapy or an attempt to change gender identity. Once again, Rafferty's questionable use of a citation is at odds with its purpose and withholds the citation's position, which endorses watchful waiting. The next reference, number 40, is a review of how the treatment of children with gender dysphoria has changed in light of clinical experience and how the demands and expectations of the increasingly younger patients have changed. It provides reasons for and against the use of puberty blockers and describes the author's rationale for lowering the age of hormones to 16, the Dutch age of majority. Even with these changes, the author still endorses the careful exploration of underlying trauma and any coexisting psychological issues in a lengthy period of screening that is in line with watchful waiting. The rationale for this cautious approach is the acknowledgement that a large majority of children with dysphoria will desist without hormones or surgery. The paper does not address conversion therapy at all for either gender dysphoria or sexual orientation. Again, the use of this citation by Rafferty in the Academy of Pediatrics position statement is puzzling and fails to acknowledge the support for watchful waiting as a legitimate approach for some patients. Reference 41 is a 2006 article which looks at the history of early conceptualization of gender-variant children, predominantly feminine boys, as pre-homosexual, and debates around early therapies focused on modifying gender-variant behavior. The therapies for modifying behavior did not address or consider gender dysphoria or gender identity, and were primarily focused on preventing children who exhibited gender-variant behavior from becoming homosexual adults. The paper tracks the debates around the formulation of the DSM-3 diagnosis of gender identity disorder in children, and concludes that there should be a shift towards a greater focus on addressing the psychosocial challenges of gender-variant children rather than foreclosing them into a predetermined outcome. This is the very process that watchful waiting and exploratory therapy allow to take place. Modern-day exploratory psychotherapy and watchful waiting are in no way comparable to early attempts at preventing homosexuality through behavior modification. Once again, the citation does not support Rafferty's position regarding conversion therapy for gender dysphoria in children. The final citation Rafferty gives in this segment is a single-paragraph statement from WPATH during the early stages of the American Psychiatry Association's update of the DSM, calling for the de-psychopathologization of gender diversity. The inclusion of gender identity disorder in the DSM has been debated since it first appeared, and there are reasonable arguments for and against it being removed, as homosexuality was previously. While not removing the diagnosis altogether, arguments such as this resulted in the change in the name of the diagnosis from gender identity disorder to gender dysphoria in DSM-5, targeting the dysphoria rather than pathologizing gender identity per se. This change does not validate the inclusion of watchful waiting and exploratory psychotherapy under the umbrella of conversion therapy. Watchful waiting is not conversion therapy. These examples bring to light important points which should be kept in mind when referring to policy statements, guidelines, or standards of care. Recommendations should be based in quality evidence which justifies the irreversible changes, potential complications, and heavy future medical and psychological burden they entail. When very low or low quality evidence still results in strong recommendations for treatments in children, careful examination of the values and assumptions used to override the weak evidence base is warranted. The reality of desistance in a majority of dysphoric children and the more recent phenomenon of detransitioners should inform all aspects of analysis. If a majority of children desist with watchful waiting and without medical or surgical intervention, then that outcome should be a baseline with which to compare any other potential intervention. Watchful waiting is not conversion therapy. The alarming conflation of the two using irrelevant, contradictory, and misleading citations is a red flag that there has been a lapse in professional review at the American Academy of Pediatrics. The AAP policy statement is not a standard of care and should not be cited as such, or used to silence debate, delegitimize critics, restrict potential research, or bolster legislative action to either enforce affirmation or prevent watchful waiting. You cannot claim that all or even a majority of the over 60,000 members of the Academy of Pediatrics support the affirmation model of care outlined in this policy statement. It was authored by a single doctor within his first year out of residency and published without public review, approval, or commentary opportunity by the Academy at large. No minority opinion or public debate was allowed. All policy statements from the American Academy of Pediatrics automatically expire 5 years after publication unless reaffirmed, revised, or retired at or before that time. This statement was initially published in October of 2018 and should be up for expiration in 2023. Members of the Academy of Pediatrics are encouraged to examine the claims made in this video and by others on both sides of this issue and actively support efforts to update and revise this statement to better reflect the academic integrity and ethical principles of the Academy at large.